Good afternoon, everyone. Um, Thank you, organizers. Thank you, ISMPOCon, for inviting me to be part of this event. So, we actually wanted to have Dr. Samir Shah from the surgeon's perspective, but he's not going to be there. Uh, so, is my screen visible?
Yes, sir. Yes.
So, I think we know that it's a very difficult to treat disease. 2007 is where sorafenib came into picture with the sharp trial, and after that, nothing has much happened in the spectrum of therapy of metastatic or advanced unresectable hepatocellular carcinoma. Till a point came when immunotherapy obviously came in the foray, and now we are seeing some silver lining in the whole bleak picture of HCC algorithm. And now we will probably have a lot of therapeutic options at our disposal to decide from. So to discuss this, we have these are my conflicts of interest and disclaimer. We have a very esteemed panel with us, as has already been described: Dr. Akshay Shivcham, Dr. Mehboob Basade sir, Dr. Tushar Patil, Dr. Suhas Agre, Dr. Nilmal Raut, Dr. Anup Toshniwal. So all are medical oncologists, and we would be discussing most real-time case scenarios as to how do we treat this patient in our clinical practice. So, so, so to begin with, let me start with Basade sir. I think he probably has the maximum experience of treating. He has seen the spectrum from chemotherapy to TKIs to IO. So, sir, in your experience, how is this therapeutic algorithm has been for you in your clinical practice, and what are the key parameters or key challenges that you face when treating unresectable or metastatic HCC?
Thank you, Ashish. Yes, I have seen the era before sorafenib when there was nothing. We used to give adriamycin and cisplatin and adriamycin intra-arterial. We used to give even that also, but had very poor the outcome for the patients. Then the sorafenib came in and something oral which probably changed the outlook, and now we have various TKIs plus IOs for the treatment of the HCC. First and foremost, very important thing is that we should use the systemic therapy when the liver function is maintained. That's the most important thing which I feel. I mean, we try to use in child B and C, then you are not going to get good results. So whenever the patient is in a good shape, that's the time one should try to use the various therapies.
Right. So I think point very well taken that I think childhood B, once you get into that segment of patients, then overall survival is so dismal, and there is a competing event of life-threatening event, which is a decompensated liver disease rather than the HCC, which sort of starts controlling the scheme of things. So let me go back to Dr. Nirmal. Dr. Nirmal, in your clinical practice, very important, as sir has very rightly mentioned, some of these liver function test dependent factors, but do you consider any other important clinical factors which could decide in making the decisions, or what are the challenges that you face?
So right now with the IMBRAVE study, we have to see for the contraindications to bevacizumab. So we have to see for esophageal varices, any bleeding, any uncontrolled hypertension, any wounds which are untreated. So these are the basic challenges that we see. Yeah.
So may I go to the further discussion? I'll start with the case presentation just to make the discussion more succinct and compact. So this is a 70-year-old male who had HCV-related cirrhosis, had a history of paroxysmal atrial fibrillation and dyslipidemia, and he was diagnosed with HCC in 2010 when he had a very small 2 centimeter segment 4 nodule. This is the history which he underwent. Historical treatment, that is, he had 4 sessions of radiofrequency ablation. In 2015, he had left lobe recurrence where he underwent TACE and then subsequently achieved a CR. Then he had 2 more courses of ablations till the time in December 2019. He had a diffuse signal abnormality, and something like this was seen in the picture. So maybe we could start with Dr. Akshay. in your clinical practice, Akshay, how much of taste and tear happens before you see a patient in your clinical practice, and what are your views on the role of loco-regional therapy, or rather liver-directed therapy, in the treatment of advanced HCC?
Uh, yeah, Dr. Ashish. Actually, as per as percentage wise, if you can say, in my clinical practice, almost 20 to 25% patient, they initially must have met with the gastro surgeon, GI surgeon, or GI onco surgeon with any liver masses. So in that, in hepatocellular carcinoma, so almost 20% they come after giving either test or tear, is a liver directed therapy. And of course, a liver directed therapy in a localized disease where the resection is not possible, or there is we can ablate that lesion. I think that's a good chance we are giving to the patient by doing tear or test in a localized setting.
Akshay, you're not audible. Can we move on to Dr. Anup? I think Akshay, there's some technical glitch there. Anup,
Yes, sir. Yes, sir. Am I audible?
yes, Anup. So maybe I will extrapolate the same question to you, since Akshay has not finished. Taste, tear, too many of them before they reach to you. What is your perspective?
Yes, sir. Around 30 to 40% of patient might have undergone taste and tear before presenting to me in clinical practice, and most of my patients are routed through medical GI only. Very few patients directly, even they directly don't present to onco surgeon. Most of them are seen by medical GI first, and then they are referred. And another issue is that most of them, they are offered first line sorafenib by medical GI. Most of them are not aware of availability of lenvatinib, or they were at this, they are not aware. So that's one of the challenging aspects of that, that the timely referral from the medical GI community is not yet established.
Right. So I think there has been a lot of literature and noise about early intervention of systemic therapy, and that's something probably over a period of time we will see a practice changing trend. But the early institution of systemic therapy probably will improve the outcome, and I think that has been fairly well proven in quite a bit of real world scenarios as well as randomized control trial. So if I may go back to Dr. Tushar. Dr. Tushar is here. Dr. Tushar Patil. Tushar, are you there, Tushar?
Yeah, am I audible?
Yes, Tushar, you are audible. So, Dr. Tushar, in your clinical practice broadly, how you look at HCC as a spectrum? Typically, transplantable and resectable vis-a-vis non-transplantable, non-resectable. How do you decide in your clinical practice when a patient comes in a non-resectable, non-transplantable state? What is your treatment of choice, and how do you go about making a therapeutic decision?
This is the situation where we had. Hello, am I audible?
Yes,
Yeah.
Tushar.
So non-transplant, non-resectable goes into what I would say metastatic or palliative kind of a setting. Here, I think our child book criteria makes a lot of difference as to whether to offer treatment to this patient or not, and if at all, then what to offer to these patients. Unfortunately, all the trials have taken only to child book A patients, very few up to child book B, and there is nothing available for child book C, because in general their prognosis is very poor because of the underlying cirrhosis or liver dysfunction. So in that child book A or B, probably even now most of us are deciding based on the finances of the patient.
Correct.
Whenever we would like to decide. Of course, all the patients, regardless of the finances, are given an option of the available therapies. Definitely we know that this combination of anti-angiogenic and PD-L1 combination is better than the single agent anti-angiogenic oral therapy available, but then it should be some subsets where possibly more advantage of this therapy is available as compared to only oral, because many of these patients still cannot take the long-term treatment which is available with these.
Correct. So I think before we deep dive into the specifics of this particular treatment concept, If I may request Basade sir to enlighten, sir, in your clinical practice, TACE, TARE, RFA, vis-a-vis systemic therapy, that's always the debate whether the patient should be with an intervention radiologist or with a medical oncologist. And what is that you see? Would you believe that these newer trends would sort of overcome the local liver directed therapies, and that could be the treatment norm?
So I follow the BCLC, the staging criteria, and based on that, then we decide whether the patient should go for the TACE, public TARE, because there is a median OS of 20 months if you do the test, which we haven't reached with our medical therapy. So if the patient is fit for TACE as per the BCLC criteria and the good liver function, I suggest to go at least one test. I do not ask them to go for the repeat test, because radiologists, once they say, they go on giving the repeat test. But with the advent of new systemic therapies, I think only one test should be allowed, if at all, and then one can move to the systemic therapy. RFA is usually, the tumors are when they are small, less than 3 centimeter. That's the criteria, and that's where you can go for RFA. Or if they are close or deep inside, then you can go SBRT, and there are so many other things. But as far as widespread disease is concerned, liver function is maintained, then one can deal between the TACE versus the other thing. Yeah, and the other important is associated hepatitis B and C, because all B and C were excluded from the IO trials.
Yeah. Ashish, I have to mention here about this study which was presented at ASCO GI 2022, which was lenvatinib plus TACE. So they did TACE for the bigger tumor and they gave lenvatinib to the rest of the tumors. And they found a median progression-free survival of 17.8 months, So that was equivalent to what was achieved with IMBRAVE and, Himalaya, the study, So I think that is a good option.
Yeah. So I think point noted there. I think there are very specific indications for TACE and TARE, and local liver-directed therapy will definitely have its role to play. And of course, as Nirmal very rightly mentioned, that there is bridge therapy. Then there is combination of liver-directed therapies plus systemic therapy, and a lot of work is being going on currently. So coming back to a first-line treatment, you have a patient like this who's received past local therapy and has got a multicentric disease. Maybe I can go back to Dr. Anup. Dr. Anup, how much the etiology matters in your decision making for the treatment of metastatic HCC?
Sir, as of now, as per the guidelines, there is no disease-related marker or etiological-related marker to be taken in account while deciding the treatment. But obviously, if you see the efficiency for viral etiology, actually IO plus DAVE combination has shown to be more beneficial as compared to the patient who has suffered HCC due to NASH. Also, there is data of sorafenib being more beneficial in hepatitis C related disease. So these are the early markers. But as of now, depending on the etiology, we do not select. We have to take other things also into account.
Correct. So Dr. Tushar, I think just alluding to what Dr. Anup just now mentioned, if you see in the supplement of the IMBRAVE 150, the progression-free survival for a non-viral was almost touching the midway. So there was not much of a benefit of DAVE plus Atizo, but of course in terms of PFS benefit, it did show a lot of improvement in all the subgroups.
Ashish,
So,
can I add before
yes,
we
sir.
add?
Yes, sir.
The Anup said that etiology doesn't matter, but in IMBRAVE trial, the hepatitis B and C were excluded.
The co-infections were,
hepatitis.
yes.
So coexisting. So if HCC is because of hepatitis B or C, one has to be careful with IO.
Absolutely. A point well taken, sir. And even for that matter, those patients who had autoimmune histology, they are also to be out. So these are the few specific etiology-based contraindications, that is concurrent infections with HBV and HCV both, and autoimmune histology from the etiological perspective could be one of the key excluding factors. Yes, Anup, you want to...
In that, no, the active hepatitis B infections are also excluded. When it was active, if it is past infection, you can give IO. And if hepatitis B and C etiology, you can still give, but both of them together you cannot.
Absolutely. Point well taken there. So, Dr. Tushar, your take on, we have seen a lot of non-alcoholic fatty liver disease converting into HCC nowadays. So, wherein maybe this particular combination, yes, it's working, but the forest plot is showing that somewhere in terms of OS benefit, it's almost touching the midline. What do you think? How do you see those faring up in your clinical practice?
I think in non-alcoholic, this combination really works well. So,
Right. Dr. Akshay, your thoughts on non-viral etiology, which is other than autoimmune. That is a large chunk of clinical patients that we see in our clinical practice. Non-alcoholic fatty liver disease causing NASH and HCC.
Yeah, basically, in that patient, we may use, excluding autoimmune hepatitis, the atezo and beva combination if patient is fit enough to undergo. But yes, I can see these nowadays. These are NFLD leading to NASH and HCC are more and more as compared to viral hepatitis.
Correct. So I think point well taken there. That as far as the etiological factor, these are the few important contraindications that we could probably not use this particular combination. But in all other combination, it's been shown to have a definitely improved benefits across PFS and OS spectrum of the disease. If I may go back to Dr. Nirmal, Dr. Nirmal, how much is the concern for bleeding when you're using combination of atezolizumab plus bevacizumab in HCC? We know that we have done a SCOPY 6 months before and there are no varices, but still, are you very much concerned about the bleeding complications associated with this combination regimen, or you are okay with it?
No, so if the SCOPY was done 6 months prior, then we have to repeat a SCOPY, and then if there is a varices, then we have to treat the varices and then give the therapy. So that is a real concern for adding bevacizumab.
Any other concern you feel is in your clinical practice for this particular combination other than bleeding?
Uncontrolled blood pressure, proteinuria, these can also be contraindications for bevacizumab. Yes.
and any other underlying arterial or venous thrombosis, which may still be there in these patients. So,
If you add this one important exclusion, the recurrence post liver transplant. Because if you do ATO, then there is 39% chance of graft rejection. And then what thing is important is patient with other autoimmune disorders like myasthenia gravis or uncontrolled other autoimmune disorders. And obviously, patients with Crohn's disease, underlying Crohn's disease, if you do bevacizumab, they might develop fistula. So I think these are the major concerns with ATO and BEV. And relatively, then obviously, patient with history of thromboembolic events and patient who has controlled autoimmune disorder. Then we have to discuss that you have controlled autoimmune disorder, but using IO might lead to the relapse of the disease.
Correct.
I have a question. Can I ask?
Sure.
So, what is the take of in such cases that now it has been pointed out, like Crohn's disease, where we have a real risk of perforation, fistula forming? What is your take on using immunotherapy plus oral anti-angiogenic therapy like Lenma?
So, Pasade sir, would you like to take this?
Combination, same combination, but the Beva is not used. We are using the oral therapy. The risk is minimal of perforation, fistula formation.
I personally don't have any experience. I didn't get any kind of this patient. But logically, if you see for such patients, one can try to use the tear and tear methods better than the combination. Well,
Okay.
There is a phase 2 trial, I think, going on for Lenva plus Pembro in HCC.
Yes,
So, yeah.
There are so many indications.
Yeah. So even in all the other diseases also. So Lenva Pembro is a TK and IO combination can be an option, if not better.
Right. So a very important, again, pertinent points to the overall scheme of things. Another important 2 points which are very positive and succinct in terms of Embrave was that these patients have, a lot of patients had a high risk disease. They had a good amount of patient with more than 50% liver involvement. a good amount of patients with a macrovascular invasion. And then obviously these patients had good response rates. So this is one of the combination where we're getting a fairly decent resist response rates. So Dr. Anup, in your clinical practice, how much response rates actually matter? Because in with sorafenib, response rates with resist was at best in 4 to 5%. So do you think this resist criteria and the response rates are critical, or do you think they are probably just a radiological nuance?
Sir, they're not very critical because the response rates are really not very good, but the stability of disease over the long period and the OS will eventually matter. And there are many fallacies of using CT or MRI for staging. You have to see all three clinical features, alpha fetoprotein, as well as the arterial phase of that triple phase CT or T1 of the MRI, and then take the decision. So, not very important.
Correct.
So Ashish,
Yeah.
Ashish, in the IMBRAVE, there are 25 patients who had a complete response.
Yes.
So, complete response in an unresectable HCC, we have never seen that,
Yeah.
know.
Yeah.
So that we have seen.
Yeah. So the results are very good, sir. Yes.
Yeah, sometimes we might find on PET scan there is a reduce in activity in the lesions rather than decreasing the size. The SCV uptake goes down drastically when patient is on any form of therapy for HCC. So that could be taken as a response only with the TK.
Now, of course, important response rates are seen. I think this is the only combination where you are seeing some appreciable resist response rates in your clinical practice. And probably for a high tumor burden disease and high risk disease, this particular response rate could translate into improved quality of life. I think that is something which we all are chasing for this this particular disease.
Ashish,
So maybe-
even in RCC, the combination of Axi and Pembro has given almost 50% response rate. So impressive response rates, combination of IO plus anti-angiogenic treatment on various malignancies.
Correct. So maybe we could go back to Basade sir. Progression-free survival was around 8.4 months. Somewhere at 9 months, patient would start progressing with this combination as well. What is that? How you see in your clinical practice? How does this segment of patients would go?
We all know that the immunotherapies in the immediate period, obviously there might be some chance progression, but those who respond, they respond longer. So the biology of the disease is also matter. If you have an aggressive tumor and where by the time in the end immunotherapy works, and if they progress, then these are the subset of the patients who are not going to do well, and those patients who have little not that aggressively developing tumors, so probably where the immunotherapy will work better. So that will also be an important point.
So very rightly said, sir. Here you could see in this particular slide the survival benefit with atezolizumab versus sorafenib. Now there is also lenvatinib which has come into the picture. Sorafenib was 2007. Now we have lenvatinib, and we obviously have lenvatinib versus sorafenib non-inferiority study. So maybe Dr. Tushar, how do you place lenvatinib vis-a-vis this particular combination in your clinical practice? So it's only the finances which decide.
I think yes, because but both the options are always given to the patient, all the patients, and given the longevity of the treatment, mostly most of them do opt for lenvatinib.
Correct. Dr. Akshay, your experience with lenvatinib?
Yeah, but do the child book scoring does matter in you approaching the patient with atezolizumab plus versus lenvatinib combination. In the trial they were mentioned only child book A, even NCCN guideline mentioned child book A, but by the time patient present with the medical oncologist, so I wonder how many of them they still remain in a child book A. Basically, patient started because of liver failure. So child book B or C, in that patient we find most of the patients. So where we can place lenva over atezolizumab in that categories of patient, where child book is B8, B9, and something like that.
So I think very rightly taken. And let me go back. Dr. Suhas Agraj, I think, joined the discussion. Suhas, sorry, I think you were not there initially. Your experience of child book B in your clinical practice, how do you make a decision? You have a patient with advanced unresectable HCC and child book B. Do you treat these patients, or you put them on best supportive care, or what is that you do in your clinical practice?
So basically for childhood B, only recommended therapy as of now would be the use of the sorafenib. But most of the patient, when we really see in the clinical practice, they may land somewhere in the B itself. So maybe we can try some of the patient on the lenvatinib, and if with the good performance status again, we can try with the IO combination also, and considering some other factors. But definitely with the childhood C, we won't use any of the available treatment options.
Correct. So in
Ashish,
fact,
with
yes, sir.
Ashish, with childhood B,
Yeah.
we can also use single agent immunotherapy, which has shown to be non-inferior to sorafenib. The latest Himalaya trial, which was presented at the ASCO GI 22, it showed that durvalumab alone was non-inferior to sorafenib, and the quality of life was much better.
Correct.
If you see the data of the childbirth B, the highest data from the real world coming from sorafenib, the Gradient trial, you know that that's the highest data sorafenib. Second highest is coming from nivolumab.
Yes.
So nivolumab also being used in second line, and that is also having a as compared to sorafenib, which is little better. But IO to give in the childbirth, in fact, the combination of the atezo with bev was tried in the childbirth B in one trial, and it showed that there are very high chances of having an adverse events, AEs. Though there is a modest activity, so they said that one should not pursue at present out of the clinical trial.
Absolutely. I think the point very well taken. Nivo and sorafenib are the only two agents where you have got significant activity in terms of childhood B. But having said so, I think all of us stumble upon these patients more often than not, and that's the clinical decision making that we have to make. Before we close, last couple of important points. There is something called a synergy and additive effect when you are combining anti-VEGF with immunotherapy. So, Dr. Akshay, your take on that? There has been a lot of hypothesis generating discussions which are happening that immunotherapy, the bevacizumab combination with IO could actually enhance the IO effect by inhibition of tumor microenvironment, immunity in tumor microenvironment. What is your take on that?
Dr. Joshi, 1 minute left, sir.
Sure, sure. So this is the last question probably, and then we would want to close.
So in this setting, I would say that in every liver cancer like in HCC, the main role is of angiogenesis inhibitors, and as we know that it is an excretory organ, so no chemo goes and kill the cancer cells. But as this is additive effect, as it is in saying, it can help adding that effect of atezolizumab when bevacizumab is combined with atezo. So yes.
Right. So I think there is quite a bit of synergy which is exploited by this combination, and if you could see the individual response rates are 12%, 13% individually of bevacizumab and atezolizumab monotherapy, and probably you are seeing a response rate close to 30% in this particular study in terms of RECIST criteria. So maybe I could close the question with Dr. Suhas. Dr. Suhas, 4 important clinical studies going on. There is IO plus IO, there is IO plus TKI, there is durvalumab, there is pembrolizumab plus TKI, there is IO plus bev combo in other immunotherapy settings. So how do you think these are exciting times for HCC? Do you think 6 months down the line you would be changing your clinical practice, or what is your scheme of things in terms of the early horizons in HCC?
Definitely, Ashish, but as we have seen, maybe 6 months or maybe a year before, there were very limited treatment options. And when we stand today, we are having a plethora of the treatment options. So maybe in the future time, with the new data coming up, I think definitely it is going to change our clinical practice, and that is going to improve the outcome for this particular disease, which we normally think of very difficult to manage.